Hi, everyone. Thank you so much for joining us today. We're going to get started in just a few minutes. We still have folks joining, so we are going to get started in just a couple of minutes. Thank you so much. Hi, everyone. Thank you to everyone who has joined in the last minute or so. We still have folks coming into the webinar room, so we're going to give it just 1 or 2 more minutes before we start. Hi, everyone. Thank you so much for those who have just joined. We're going to get started in 1 minute. If you have any issues with hearing me, I am speaking right now, please type any questions into the Q&A box and we can have one of our technicians help with any audio or visual issues. So we'll get started in just 1 minute. Hello, everyone. Thank you so much for joining us. We're going to go ahead and get started. We may have some folks joining us as we get going, but just want to say thank you to everyone for joining us today and welcome to today's webinar on how Memorial Hermann Health System is bringing precision healthcare to Texans through the use of population genomics. My name is Emily Richmond, and I am a strategic advisor at Helix, and I'm delighted to be moderating today's webinar. On behalf of Becker's Healthcare, thank you so much for joining us. Before we begin, I want to walk through a few quick housekeeping instructions. Today's session is being recorded and will be available after the event. You can use the same link that you used to log into today's webinar to access the recording. Feel free to share it with others as needed. If at any time you don't see your slides moving or you have trouble with the audio, try refreshing your browser. You can also submit any technical questions into the Q&A box. We are here to help. We have folks standing by if you have any issues. Here's a look at the agenda for today's session. We will begin by hearing a bit more about Memorial Hermann and Helix. Then we'll get into details on population genomics, precision health, and the value they bring to patients, providers, and the community. You can use the Q&A box to submit questions throughout the presentation, and we will have time at the end to answer them. With that, I am pleased to welcome today's speakers, James Liu, co-founder and CEO of Helix, and Feby Abraham, Chief Strategy Officer at Memorial Hermann Health System. They are the experts here today, so I will let them introduce themselves and their organizations. James, Feby, thank you both so much for being here today. I'll now turn the floor over to James to begin.
Thank you, Emily. Thank you, Beckers, for having us, and thank you, Feby, for being here with us today. Before I dive in, this is a particularly fun conversation as someone who spent time training in Houston and spent a little bit of time training through the Memorial Hermann system as well. So really excited about this upcoming conversation here. But just a bit about Helix. Helix is the leading population genomics and viral surveillance company in the country. We have kind of three main arms today. One, a major focus on population genomics in the context of health systems. A second, focus on public health and viral surveillance and infectious disease. And third, around life sciences. But today we'll spend the vast majority of our time talking about our programs in health systems related to population genomics and our partnership that we recently announced with Memorial Hermann. So I'll hand off here to Feby to talk a little bit about their organization, and we'll kind of dive right in.
Thank you, James, and thank you, Emily, and thank you, Beckers, for the opportunity to discuss this great partnership that we've just launched with James and the Helix team. Just to talk about Memorial Hermann itself and the value of the Helix partnership, let me do the following. Let me just sort of introduce who Memorial Hermann is, then get into what we stand for, and we'll then talk about like the partnership with Helix. Just to introduce Memorial Hermann, we are one of the largest health systems in Texas, the largest here in Southeast Texas, and we serve a community of greater than 7 million people here in Greater Houston. How do we do that? We do that through more than our 6,500 affiliated physicians, more than 29,000 employees that practice the highest standards of safe, evidence-based, high-quality care. And we do that across 265 care delivery sites. We have about 17 plus hospitals and numerous specialty programs and services that are conveniently located for the access of Greater Houstonians. Memorial Hermann Texas Medical Center is one of the nation's busiest level 1 trauma centers, as many of you might be aware, and serves as the primary teaching hospital for the McGovern Medical School here at UT Health in Houston. We've been around for more than 115 years, and our focus has been for the best interests of our community. We invest significantly annually through our community benefit programs. We are, as you can see at the tagline at the bottom of our slide, we stand for advancing health and personalizing care. And through our commitment in advancing health and personalizing care for all the patients we serve, we view this partnership with Helix as a tremendous opportunity to strengthen our commitment, as we'll get into momentarily. If you go to the next slide, just to sort of recap what Memorial Hermann's mission, vision, and values are. Our mission is we are a not-for-profit, values-driven, community-owned health system dedicated to improving health. Our vision is to create healthier communities now and for generations to come. And our values are we stand for community, which really means we value diversity and inclusion in community, to being the best healthcare provider, being the best employer, and the best partner. We practice with compassion. We understand our privileged role in people's lives and care for everyone with kindness and respect. Credibility, where we conduct ourselves and our business responsibility and prioritize safety, quality, and service when making decisions. And courage, where we act bravely to innovate and achieve world-class experience and outcomes for our patients, our consumers, our partners, and the community. Go to the next slide. James, over to you.
Yep. Thank you, Feby. And so when we think about genomics in the context of the healthcare systems, we often first think about the major trends that are happening in healthcare. I think the first one when we think about the use of genomics across care systems first is that we likely believe it's going to be a macro trend on healthcare, much like radiology was. So genomics will permeate all parts of the medical system over time. And even though it's being used today, particularly in specialty areas, we think it will be practiced in all parts, including in the primary care setting. And part of that is driven by our understanding of the major components of health determinants and disease determinants. The ones that are often talked about first are obviously behavioral components relate to the individual or patient's behavior. So do you smoke cigarettes? Do you eat a proper diet? Do you exercise? Obviously, there's been a lot of discussion around environmental and social determinants related to access to care, access to clean running water, access to living in a food desert, et cetera. And a third component, which is often described but has been historically much harder to ascertain, has been around the genetic and biological component. And so if we think about the three major buckets of risk, and they're roughly cut up into a third, depending on the literature you look at, we think it's going to be essential for health systems and providers to understand the genetic and biological components to properly manage disease risk in the future. And so when we think about genetic data, particularly the piece that's been inherited by individuals, we think there's a really big opportunity in terms of leveraging that from a population scale. And so when we first think about how it's used today, obviously it's mostly focused on single service lines. So almost always when we survey the field and ask people how they think about genomics, the number one thing they talk about is first oncology, and secondarily typically women's services. But we do think the approach over time is shifting more and more to a population level scale. And the key has been generating evidence base around using that at the population scale to ensure that it benefits both the patients, but also drives the right kind of ROI for the systems as well. The second component has been really focused on genomics as a test. And what that often means is that genomics is being used as a one-off resource to answer a very specific question and get almost effectively a binary answer of yes, no, on the presence of a variant. And when we think about genomics as an accompaniment to the patient over a lifetime, that if you can really sequence it one time at high quality, attach it to a patient over the lifetime, and make sure they can come back to it, that digitization of that data should really drive both speed to answer providers as well as a much lower cost of access, because digital queries will almost always cost less than chemistry. And lastly, as we think about the data as a potential strategic asset for the organization, having that and building it around a research backbone allows us to continue to benefit from future discoveries down the road and leveraging those continuously in the care of that patient. And so we really think about how do we leverage genomics in all parts of the healthcare system and driving both today's applications, but also the future set of applications and building a platform around that as well. And so how does Helix really think about this from the deployment of these programs in the context of major health systems? We really do think it's going to be an end-to-end approach, both from the data generation component, so really operating one of the largest CLIA-CAP exome facilities in the United States. The second one is around how do you make it easy to do, so workflow creation or orchestration. And we like to think internally that genomics over time needs to be as easy to do as doing cholesterol testing. And third, how do you drive advanced analytics around the data that gets generated, both in combination with the genomic data, but also potentially in combination with the medical record data. And so when we work with our partner organizations, we work together on developing that genomic strategy across an organization, executing a sustainable model, driving that clinical impact, growing the digital biobank, and engaging other potential partners over time. And this precedes itself along a series of workflow steps that enable this to work both on the clinical side, but also within the research organization, within the partner health system. And so when we started this journey in 2018, I think the idea of genomics becoming standard of care was something that was often talked about, but it was hard to achieve. And so when we were in 2018 starting these programs with Renown Health over here, I think the only other major program at the time was really Geisinger. And those two programs, I think, really generated some of the foundational evidence base that allows these programs to start to scale, both from an operational perspective, but also the clinical evidence to support the implementation of these programs. And so when we look at today's world, Helix is obviously excited to partner with a series of what we think are progressive, forward-thinking health systems across the country, really engaging in population genomics at scale within their organizations and trying to put forward precision population health across the organization today. So I'll hand over here a little bit to Fabi to talk a bit about their strategic rationale and why they've engaged in population genomics efforts.
Yeah, thank you, James. And as we kick off on the strategic rationale, what I thought I'd do is sort of talk about our overall strategy and where and how does our partnership with Helix fit in within that context. Overall, just to sort of set the stage for this slide, we view healthcare costs as untenable here in the United States. On its own, we spend more than 4.5 trillion nationally. That by itself is the third largest GDP. US healthcare spend is the third largest GDP. The outcomes, as you've read from a lot of reports, with lots of debates, passionate debate on the topic, at least with the leading Western countries, hasn't kept pace with the rate of inflation of healthcare spending. At the same time, the consumer experience and the treatment that a lot of us get in our personal lives through use of more technology disruptors, whether it's in our media consumption, whether in our e-commerce consumption, has not translated very well to healthcare just yet. And the level of digital and analytics adoption, at least, and the consumer experience that goes with it has not kept pace. At the same time, a lot of our disruptive forces are coming into our industry outside of health systems, whether it is driven through managed care companies or payers, or through technology companies, or some of the innovation that we as health systems are driving. So to overall using that as the bedrock or foundation of what we see as some of the core beliefs that shape how our strategy is set up, we often use at Memorial Hermann the acronym of how do we shape the community health through a word called health, which encapsulates our strategy. Let me just dig into each one of these and show you how several of these components touch in our partnership with Helix as well. The first H that you see is around humanizing every experience, that is building a differentiated, personalized experience for our patients, our consumers, and our physicians to continue and attract and retain an exceptional workforce and create a very sticky and satisfied consumer base through engagement and empowerment. The same also holds true for our providers and our caregivers. Second is on ensuring high reliability care that drives evidence-based medicine throughout our platform, drives unnecessary variability out of the system by standardizing clinical protocols and creating a consistent experience on quality and outcomes. Third is to align our provider network, where we align our physicians in a pluralistic model through a combination of employed physicians, academic physicians, as well as affiliated physicians in the market that collectively contribute to about 6,500 physicians that are integrated through our clinically integrated network to drive success in both a fee-for-service world as well as in a value-based world. The fourth is around lowering total cost of care. I already mentioned how US healthcare costs are untenable on its own current historical momentum trajectory. And how do we identify and capture savings across the system in reducing the total cost of care, both clinically as well as through administrative and operational workflows that all collectively reduce the total cost of care? Transition to value, that is positioning the system for success under a value-based care environment where our incentives are completely aligned in reducing total cost of care alongside employers, alongside government payers, as well as commercial payers, and consumers who increasingly take the burden of paying more from their pocket and deploy population health services to best serve the community in reducing the total cost of care and therefore driving a highly aligned ecosystem to transition to value that deliver on the triple aim of cost, quality, and outcomes, as well as experience. And finally, harnessing smart growth, where we optimize leveraging our service lines through which we've organized our care delivery ecosystem, our alternate sites of care that sit outside the four walls of our typical facilities, get into the care at home or outpatient capabilities across the care continuum, and explore smart growth and partnership opportunities alongside platforms such as Helix in support of our strategic direction. So I thought this slide is a good articulation of where we see our vision for the core beliefs of the future, but also encapsulates our strategy. And why is it helpful to lay this out is because if you look at our personalized precision medicine approach that we've taken on with partners that Helix plays a big part of in advancing health and personalized care, it checks on every one of these boxes in humanizing experience, in it driving down total cost of care, and ensuring high reliability care, creates a great deal of stickiness with our provider network, helps us play in both the fee-for-service and value-based ecosystem, and leverages a smart growth philosophy versus investing on those capabilities directly ourselves and trying to de novo build it, but actually working with partners that bring best-in-class capabilities like Helix to deliver on our mission and our strategy. So if you go to the next slide, specifically when it comes to the population genomics program, as I outlined how it fits within our overall strategy, there are three specific levers that I'd sort of encapsulate all the value proposition drivers. One is around improving clinical outcomes through earlier disease detection, identifying risks, monitoring, creating a plan alongside providers and patients to manage the patient's treatment pathway, the clinical pathway, in an evidence-based approach, thereby driving better clinical outcomes and ensuring that we're enabling the care for the right patient at the right place at the right time. So that's how we see that first value prop in improving overall clinical outcomes. Reducing total cost of care, we are sort of through early identification of the at-risk patient population. That results obviously in a more proactive intervention and management of disease than a more reactive disease management at the back end. As a result, we can reduce total cost of care for that patients, especially for that high-risk pool. And finally, shaping the market. We want to be a leader in personalized care and precision medicine and innovation, leading to better engagement with our community of patients and providers that include our physicians and other care providers. Second, we want to lay the foundation for our research capabilities at Memorial Hermann and broaden and strengthen our academic and research partnerships that already exist and those that we want to expand and deepen. And finally, expand the reach of patients we serve through our overall mission on advancing health versus healthcare by engaging more earlier in the disease continuum than later in fixing healthcare. Go to the next slide. Dovetailing into that overall vision on our strategy and where precision medicine and personalized medicine fit in, what's the population genomics and precision health approach at Memorial Hermann that we've leveraged alongside Helix? We are engaging in one of the largest population health research programs in Texas alongside Helix. Our goal is to recruit about 100,000 patients over the next handful of years. And this will be used by Memorial Hermann to define how we provide health for the communities we serve. We are going to innovate the care delivery to inspire patients on taking more proactive upfront interventions, as I mentioned. And the key clinical objectives here is to improve patient outcomes, reduce total cost of care, and expand access. That's the third part I mentioned around the shape the market lever value prop in my previous slide. From a research perspective, innovation is a core component of what we want to do and provide for our communities. We want to accelerate our innovative clinical genomics research and become a leader in genomics research, leveraging our partnership with Helix. Over to you, James, to articulate more of the CDC Tier 1 value props from Helix.
Yeah. I think fitting in with much of what you said in terms of checking the right boxes along Memorial Hermann strategy, I think CDC Tier 1 is a great example of a clear screening-based protocol as part of the use of genomics as standard of care that achieves both preventative medicine, but also, we think, over time, total cost of care. So the CDC Tier 1 is the Tier 1 of actionable conditions that are most modifiable if caught early. And they're basically focused on BRCA1, BRCA2 related to hereditary breast and ovarian cancer, Lynch syndrome, as well as familial hypercholesterolemia. And we really focus on these conditions because they're highly penetrant conditions that have well-described disease penetrance. It's very clear that if you act early, that people can get effective treatment and diagnosis early and prevention, and that the benefits of the treatment clearly outweigh the harm. And there are guideline-driven activities that can be provided to providers to make sure that we have the right action plan for these patients and close that care gap. And I think some of the key things that have been really enlightening as we've gotten these programs up and running is really kind of looking at these questions on an unbiased basis and asking how many patients will be impacted, how many patients today would be undiagnosed in the current healthcare system, and how many patients, if we just looked across the full cohort, would already have advanced disease based on genetically relevant variants. And so this study we did with Renown Health and published in Nature Medicine in 2020. But along those key questions, for those 3 conditions and 11 genes, about 1 in 75 to 1 in 60, depending on the population, will be carriers of a known pathogenic variant in one of these 3 conditions. But I think the most relevant fact and most interesting fact was that 90% of these patients would not have been detected in standard medical practice. And when you went back and ascertained for family history in these populations, 80% of these patients say they have no family history of that disease within their in their family tree. And so largely, the ability to detect these patients using current protocols, which is almost all family history based, would have been challenging at best. And most of these patients would have been missed. I think also relevantly, if you just look across the cohort, in our population, 22% already had advanced disease that was relevant. So they had cancer-related syndromes, breast and ovarian cancer, and or atherosclerotic events, which is not surprising given the biological impact of these particular variants from a genomics perspective. And if you look at the survival curves of these patients to first disease incidence, I think the expectation is about 50% of them would show disease by age 60. And so really catching these patients early, we have a very, very good chance of having a very life-saving impact on these patients. And so it's one of the key things that we focused on early on was how do you make sure that the evidence base is there and you can really get the clinical impact that you want to have from these kind of broader-based programs. So I'll hand off to Feby as he talks about a little bit about the community impact that's expected in these programs.
Yeah, just building on what James just articulated, there is just from the community impact and community benefit, as we recruit broad populations who may not have engaged in preventative care previously. James just gave you statistics on the higher levels of prevalence, the 1 in 75 patients that he mentioned, 1 in 75 of the population being affected by the disease and 90% of them going in undetected. That's the problem statement we are after. We're trying to sort of provide an access and an offering to the community for all of those patients, which over 330 million people or plus in the United States adds up to a significant population base that over time lead to poor clinical outcomes, but also higher cost of care. How do you provide a better benefit for that community to access these differentiated services and be much more proactive and engaging in their own healthcare? That gets me to the second point around patient engagement, which is immediate engagement by the patients to be more proactive. And they'll have to do that. Healthcare is complicated alongside providers, alongside experts who provide them the best clinical and evidence-based protocols or guidelines of how best to manage the condition they have. And point of care insights in that future access to genomic insights at the point of care enable a more personalized treatment. I was talking about the right patient at the right place at the right time. How are we able to unlock where is it that the patient needs to engage better with a primary care or specialist because they're at risk of A or B? Where do they need to go to an urgent care location or a facility for a specific type of procedure? And where do they need to have a more post-acute type of management or a more remote patient monitoring type of approach for something that is more chronic? Creating that bifurcation across all of those choices, these trifecta of choices, and it requires us to create the best clinical decision support. That needs to be powered through a slew of insights that include some of the pieces that James was articulating in those tripartite slide he introduced earlier across demographic, behavioral, clinical, genomic feature sets. All of those need to be integrated in order to make those choices. And that is what we mean by the point of care insights.
So just to interject here really quickly, I think, Feby, it would be great if you could touch a bit more on some of the ROI drivers that Memorial Hermann was looking at, especially thinking about fee-for-service versus value-based care, in addition to some of these other benefits that are serving the community.
Yeah. Good question. If you take all of these value drivers or value propositions that I mentioned earlier, it all comes down to a few different factors. One clear driver, and I'll sort of give an answer at the high level, Emily, and then sort of describe how it translates into both the fee-for-service and the value-based areas. So number one, we have an opportunity to engage and provide access to patients to identify what they're at risk of and more proactively manage. That creates higher engagement with a broader patient population or potential patient population, and therefore retention across the system. So you're working with a newer cohort of patients who are accessing more preventative health and proactive management of their condition versus fixing what is already detected at a later stage. Second, as I mentioned, this partnership with Helix touches on a number of our strategic value drivers. Particularly, I talk about the reducing total cost of care. You reduce unnecessary utilization of expensive procedures where it can be avoided, or sort of have, through more proactive management, utilize a much more cost-effective solution upfront versus trying to sort of solve the problem in a more complicated and complex fashion at the back end, much more later in the disease progression. As a result, through the Helix's query once or sequence once, query often approach, we are able to detect disease earlier and therefore reduce that total cost of care. The third major value driver comes in through leveraging the use of data to generate insights alongside Helix and other commercial partners who are using this as a research and insight approach to better create an actionable, personalized care pathway that in its own has its own revenue potential to create that type of clinical decision support powered through data. And so we see that as a significant wave for building alongside James and some of our other strategic investments, candidly, an approach that we are sort of building towards. So those are the three value drivers. They apply, of course, very differentially across fee-for-service and value-based patients. And so for the fee-for-service patients in particular, greater provider engagement, greater retention and attraction of patients, and therefore managing their continuity of care and leveraging that insight pathway becomes more relevant. All those feature sets are equally relevant in the value-based franchise, but in addition, you also are directly managing total cost of care for patients you're directly at risk of either the full or over the full dollar on a delegated capacity. And through partnerships, we want to unlock greater service for that patient pool as well. James, you want to touch on the foundations for research efforts, and I'll take it how that translates from a Memorial Hermann perspective?
Yeah, I'm happy to. I think just also thinking about your comment on the transition from fee-for-service to value-based care, and how do you start in a world where you have effectively most systems have a fee-for-service chassis and want to move in this direction? How do you use this data to really think about both clinical best practices, but also driving net new application development that allows you to really make that transition hopefully more seamlessly? So as mentioned before, this is structured under a research protocol, and part of the reason we do that is to ensure that patients are consented for the use of these data to really kind of analyze the data in the right way. I think one of the things that we're most excited about is, as we started to work with multiple health systems across the country, is that there is starting to be an informal network of best practices sharing, both in the scale of these programs, but in working with the right patient populations, trying to figure out where we can drive the biggest impact and also figure out the right type of applications to drive over time. And so as we think about a world transitioning from today, where it is very much focused what we call a phenotype first world. So typically measured first by a visit to the physician, measuring a bunch of physiological evidence or of data points, into a world where molecular data will be much more easy to generate, will recently get lower cost, is a world where we start to see more of that trends into what we consider a more genotype first approach, and using that as the basis for then ascertaining subsequent risk of disease. And then how do we kind of do that in the right type of infrastructure that drives, that allows us to kind of ask these questions on the health systems research side and lay that foundation for broader research partnerships, both within the system and partner academic institutions, but also external to the system with other industry partners and or nonprofits that'll be interested in these types of questions over time. So really kind of how do you kind of foster a broader set of innovation discovery across Memorial Hermann, but also across a broader network of health systems too. So I'll hand it back over to you, Fabi.
Yeah, and just if you stay on that previous slide for a moment, I just wanted to sort of hit on a couple of points that James hit upon, just to sort of lay the current state of where genomics research is integrated with clinical care. It's in its early innings. We all are aware of that, but we are betting and want to shape that future where across many of the components that James hit upon, we want to shape the future of care that is much more evidence-based, drives total cost of care down. And in order to do that, we think there is a roadmap that one has to sort of get through. First and foremost, we'll need to build that foundation. There are a lot of here and now applications that James alluded to in a CDC Tier 1 applications that are higher level we can access for the patients that we integrate with in the early stage. But what we also are encouraged by is that this is also a sequence one query often approach whereby we can work with Helix over the long period of time to actually leverage those insights from a longitudinal and dynamic approach, and leveraging the best practices that already exist, scaling and building upon the foundations of broader research we would have created alongside Helix and other health system partners, and frankly, other points of the value chain, such as biotech and other leading organizations that are creating the next wave of innovation, will be able to create the right type of insights over time that then become a great vehicle for us to, over time, power a much more tailored and personalized pathway to how to treat the patient. So we are creating and accelerating this flywheel alongside Helix to sort of be able to do that. And that enables us to drive, in addition to creating the foundations for broader research, we have existing, as I mentioned in the introduction to Memorial Hermann, existing academic partnerships alongside several key partners, particularly UT Health across our Texas Medical Center and other community locations. How are we going to sort of further bolster those partnerships to sort of be able to create the next generation of insights and therefore foster innovation and discovery is a big focus for us. And that then dovetails to this next slide, which sort of articulates those 4 points that we want to provide that improved access for those community stakeholders, including patients, employers, payers, to engage in a different type of dialogue on preventative and proactive, I should say, healthcare versus more reactive after the fact. We want to be a national leader in precision medicine, in what is shaping a market-shaping move for the healthcare ecosystem as a whole. And we want to be at the forefront of doing that, attract and retain clinician and research top talent who alongside us will partner in creating many of these new innovations and insights that shape that future. And as I mentioned, accelerating new research and discovery opportunities alongside Helix, other stakeholders in the value chain, including health systems and other points in the value chain, to define and transform the healthcare problem statements we all are currently faced with.
James, Fabi, thank you so much for that really insightful presentation. We've had a lot of really great questions coming in, so I want to use the rest of the time to touch on some of those questions. The first one I'm going to direct to you, Fabi. Any advice for other health systems that are trying to decide whether or not this type of program is right for them? What's some advice that you would give to them if they're evaluating this type of program?
Yeah, I think I would sort of go back to why you're doing it, why you even exploring this type of dialogue. If you're committed towards some of those value drivers I mentioned, which is reducing total cost of care, creating better clinical quality and outcomes, greater provider and patient experience, this is something that needs to be in your flywheel of exploration. So for any health system that is thinking about delivering on that triple aim, whether you live in a fee-for-service world or in a value-based world, a precision medicine approach for selecting a right patient, right place, right time is the right philosophy in my view versus taking a broader one-size-fits-all philosophy. And therefore, you all need to be exploring this type of equation. If you then sort of go to question two, you come to the answer to that first question as being a check, is thinking about your various constituents, your providers, your patients, your research efforts, your value-based versus fee-for-service exposure, and then thinking about, as a result, what is the value prop drivers that you as a system would articulate. And I just shared with you throughout this presentation how we at Memorial Hermann thought about it. You all may come to very similar or potentially similar value prop drivers. If it does, then you need to sort of go to that third question, which is, what's the economic case? And when you think about the economic case, I mentioned a few value drivers, particularly around how you become a platform of choice for new patients or expanding access to patients who are more proactive. How do you sort of create more active engagement with providers? If you're like us, we're working with a broad swath of independent affiliated providers in our network who are looking for options to drive innovation across their patient care. This becomes a very important slew or a value prop driver for that. So that was one. Your fee-for-service versus value-based economics is something that you can easily develop a business case on. And then how do you sort of provide that continuity of care for that high-risk patient pool who you've identified, the 1 in 75 patients, 90% of who are undetected, as James was mentioning throughout this. My one word of advice after you go through that very logical 1, 2, and 3 pathway that I mentioned would be, you're also at this point where you're shaping the medium to long-term future. There are many value drivers in health systems that is chasing the here and now. So if you're looking for a value driver that says, look, I'm sort of looking at every healthcare investment opportunity or transformation opportunity in a 12-month time frame or a 24 to 18 or 24-month time frame, that may be the wrong type of question versus saying, how do you provide a sustainable value prop with a look towards a 10-year future? How are you going to shape it? As you sort of answer those 3 questions I laid with that long-term vision, some of these investments and creating industry-leading programs like this become step 1 in a longer journey, and therefore can become much more creative as you think about the business and community cases for why you should do it.
Yep. Thank you. That makes a lot of sense. And I think that there are probably a lot of health systems that are really thinking about whether this is right for them. And I'm certainly happy to take questions after for those that may want to learn more. We have so many questions coming in, so I want to jump to another one. James, I think this would be a great one for you to answer. What do you think it will take for genomics to become standard of care? What are sort of the hurdles that need to be overcome in order to move in that direction?
Yeah, it's a great question, but I chunk it into kind of 3 main buckets. The first one is I think the very clear question is, does it benefit patients? And I think that is becoming increasingly clear, and the preponderance of evidence, totality of evidence, is suggesting that this will be good for patients on a general basis. And so there will continue to be work there, but as these programs start to scale, we'll continue to see more reinforcement across more different care settings. I think we'll find that very clearly this is one of the most efficient mechanisms to define patients that are hiding in plain sight today, that are at risk. I think the second big bucket is around readying the workforce and making it easy to do. And there's been a couple questions around physician education, how do you kind of absorb this workflow within a primary care setting, et cetera. And that's much of our work today in partnership with the health systems, is how do you make this as easy to do as possible? How do you make sure physicians are prepared at the point of care? And how do you make sure they have the right level of education to make sure patients really close the care gap, And I think one of the key things we looked at early on was a model of more of a direct to patient return facilitated by genetic counseling. And we asked the question, if you had this almost as an independent service outside the healthcare system, what would happen to these patients? And so, in about 25,000 to 30,000 patients, we had this kind of facilitated GC return. They went to their own personal physician, and then we asked the question at 1 year, how many had the appropriate care plan? And the answer was a little bit sobering, frankly. It was of about 100 pathogenic carriers, so this is in your heads, 100 patients with like a BRCA positive type of finding, obviously very salient. A third of those patients basically never went to the providers. Rescheduling issues, couldn't get in, got busy with life, et cetera. A third went to their physicians, and the physicians basically could not put them on the right care plan. And then a third did get the right care plan at 1 year. And so as we think about these programs and achieving that ROI, both from a clinical perspective, but also from an economic perspective, we have to make sure that that care gap closure is incredibly tight. And so that's probably the next big bucket of like, how do you kind of achieve the ROI that you expect? The third one is what I would consider around payment models. And we do a lot of work here in partnership with our health system to make these programs free to patients, equal access, and broadening access across the community. And that helps achieve both goals of diversity and inclusion, but also ensures that all populations within the local community get access. But I think the biggest problem, obviously, in those healthcare is that there's a durational mismatch between risk and investment. And so organizations today that would have to pay today to benefit 3 or 4 or 5 years, 10 years down the line, that mismatch often makes it hard for you to make investments today in preventative care. So I think for a lot of, we're not positing that Helix is going to transform that overnight. But I do think as we think about economic ROI and ROI of the health systems, we have to pull forward the ROI as much as possible to make it viable for these programs to exist.
Thank you, James. Next question, and I want to say before I read this one that we're probably not going to have enough time to answer all of the questions, but we will follow up with everyone who has submitted a question via email. So feel free to submit more questions, even if we are getting a little bit closer to the end of time, and we'll make sure to follow up with them. So I thought this question was especially interesting. It says, although patient behavior modification is challenging, provider behavior modification is even more challenging. Helix provides a wonderful tool, but I'm wondering what FEBI and Memorial Hermann are doing to bring providers along on the journey. And a similar question came in sort of, what is the role of primary care as part of these programs? And I think it's similar to that, bringing primary care in with those providers. So FEBI, do you want to touch a little bit on that question?
Yeah. First of all, I want to acknowledge the comment that was made in the question that led to the question, that provider engagement is by far one of the most important factors that sort of drives adoption of a program like this. And therefore, we view this as a multi-year journey for us to sort of start to get the flywheel in motion and then sort of accelerate that over time. And how are we going to do that? We're going to do that, first of all, before I do that, we are sort of alongside Helix and our own provider networks and service lines creating a thoughtful implementation plan to sort of work through getting a lot of these components in place. So we're still working through the specifics of how that plan will be. But at the front end of it, leading health systems like us will need to be at the forefront of innovation and talking about the next generation of clinical care. Once our clinical leaders who show that type of commitment, we need to sort of bring in the champions. The champions are those physicians who have had a lot of exposure and have got great demand for a program like this, whether it's primary care and several of our key specialties, to embrace this concept as something that they bring for their patients. And over time, use that as a nucleus to sort of engage with a broader set of providers to both educate and bring them the value proposition drivers on these. It is not yet a holistically adopted standard of care, but to James's point, a lot of great evidence on how this is being utilized as the next forefront of clinical care already in leading settings. So we need to bring that to the providers in the journey, and it will be a roadmap. And as I mentioned earlier, the less one can sort of think about this as a 12 to 24-month roadmap, but use that as a vehicle for a multi-year journey that sort of accelerates and ramps over time, creating good wins and sort of appropriate engagement with a leading set of key opinion leaders, and through them translating to the broader provider community that leads to more engagement. And we've been in discussion with a few other health systems that are in second innings of this implementation roadmap and are obviously learning and benefiting from that. So if your health systems are considering opportunities like this, we're obviously happy to sort of share our notes on how we are thinking about that holistic provider engagement roadmap.
Great, thank you. We've had a few questions come in on this topic as well, so I want to make sure that we get to it during the live session. Commercial payers are often reluctant to pay for genomic testing. How will you all overcome this? And as you're working to overcome this, how is this type of program being paid for? Who's funding it? A few questions along those lines. Would love to hear from Feby, James, either of you on that question.
Terrific. James, you want to go first? You want me to?
Why don't you go first, and I'll provide color if necessary.
Yeah. There are two things that are true of U.S. healthcare, both right. One is that payers have not, given the early innings of this journey, adopted genetic testing at scale as ones that's a reimbursed category. Two, contrary to other sort of more developed markets, which have sort of got the benefit of single payer, where whichever side of the political aisle you are on single payer, one of the things that is true of single payers is that you hold the patient for their entire journey. So if you think about the NHS in the UK, they have the patient for life and therefore are looking for long-term health decisions that span years and decades. Whereas a lot of U.S. healthcare payers are engaged on an average commercial payer holds a patient for no more than 2 or 3 years, just because the levels of employment and the Great Resignation probably has accelerated or diluted that time period of each commercial payer patient engagement. So for a variety of reasons, I want to just sort of bolster the comment that payers are not yet, and I'd sort of use that frame yet as well to sort of describe how they are thinking about this as a reimbursement category. As James mentioned, therefore, Helix and Memorial Hermann in this case have partnered to create a no-cost approach for patients to engage in this type of testing for our community. And we have, through some of the financial ROI drivers, principally by reducing total cost of care and creating an evidence-based pathway that incentivizes that type of cost, quality, and outcomes focus, come to a business case that sort of provides us the opportunity to be able to deliver that for our community for this specific program that we mentioned across all the value drivers. But it also behooves on us over time to sort of do a couple of things. One, similar to provider engagement and education, which was the basis for the previous question, also educate employers who are the payers for a lot of self-insured employers are, and even for fully insured employers for whom payers are the risk-bearing entity. How do you sort of educate employers, governments, and payers on the value proposition and reduction of total cost of care, and how clinical outcomes will be a lot better through a pathway like this? And that type of conversation and engagement, we believe over time, will make this comment or question on payer reimbursement a dynamic equation, in my view at least. I can't predict, and I'll probably get it wrong, whether we'll get payers into the dialogue in 12 months, 6 months, or maybe even 5 years. But I think we need to actively shape that dialogue to be able to do that. And in the interim, do what is right for the patients, do what is right for clinical outcomes, and do what is right to reduce total cost of care.
Maybe I just also comment just directly based on some of the conversations we've had is there's a bit of a chicken and egg in this space, right, where everyone benefits from the generation and the formation of these programs, but who puts the economic case together, I think, has been something we've been circling on for some time. I would say the payers, my expectation is they will come, but they will come over time. And part of it is they're already starting, and many of our kind of side discussions have been starting explorations into what this looks like in the future state. And I would say that they probably share much of people's view, which is this is inevitable at some point. And so how do you kind of structure the right economic case, given their, frankly, financial incentives as well? And how do you make it viable for them to do this? And how do you kind of put the whole picture together? And so we continue to welcome the dialogue, because I think as we look at the ROI case over time, it's going to be very clear that these activities do drive improvements in total cost of care.
Great, thank you. On the same lines, but with respect to getting these patients enrolled in the program, how do you enroll and consent patients? What is the messaging that's used to help them understand the benefits, and what is it that they're actually consenting to as part of this Helix and Memorial Hermann partnership?
James, you want to take that?
Sure, I'm happy to take that. So as part of the process, patients are consented both as a research protocol, but also for clinical use of the data. And so Helix generates for every single patient the same exome plus data set, which is a broad-based assay that covers a broad swath of the genome. That enables both the research applications that we talked about, which every patient will do a kind of broad biobanking type consent for. That allows us to contribute the data into a de-identified database and use that for future research, application development, as well as driving future clinical use cases. And the patient also benefits from the use of that data to help them with identification of early disease, as well as the sequence one query often model that Fabby was talking about earlier, which is the ability for a provider in the health system to come back in future cases and use that data in a point of care type setting. And so, one of the things that we're really excited about are situations like pharmacogenetics, where today a physician who wants to use it to titrate a drug may have to wait 4 or 5 weeks for a result. In a Helix setting and a go-forward basis where patients are already sequenced, that order to result cycle can be less than 5 minutes. And so really, how do you turn that use of data into a more of a digital aspect and really transforming how the provider will use that data, but also how the patient benefits over time?
Great. And I think that we have time for one more question if we keep it short. And like I said, we will follow up with folks who didn't get their questions answered via email after the session. So we'll say with this one, Febby, you talked a little bit about the ROI for Memorial Hermann. What was the time frame that you are looking at, or what is the time frame that you all are anticipating for some of those ROI benefits?
I mean, there is, as with any sort of financial cases, as the question is specific to that, there is a ramp. So you think about, let's say, building a 5-year financial model. In a first year, one would expect more investments than returns. And that obviously, titrates over time to fewer investments and sort of, getting to some of the more meaningful returns. So we take a approach that is, and I would, for those folks who are sort of thinking about an approach like this, I would break down the ROI components into sort of 2 dimensions. One is, what do you sort of see as the financial ROI drivers in a 5-year business case? And using all the assumptions and value drivers I mentioned, where are you in that equation relative to your commitments and returns? And where do you see sensitive assumptions? How are you going to model that? And then second is, what are you doing if, depending on the success of that first phase, what are you using that as a beachhead to build over long periods of time? That business case obviously becomes even more larger, but then you're able to sort of create a more high-level picture up front, but use the findings of the first program as a way to shape what you do for the longer period. I would encourage anyone who's thinking about an ROI for developing a financial ROI, just think along those 2 dimensions. Clearly, you'll have to come to a good financial accretiveness of equation in that first phase, but don't miss the sight for how you sort of use this as to shape clinical care for the longer periods of time and what that means for your system.
Great. Thank you so much. That is all the time we have for today. I want to thank James and Febby for an excellent presentation, and Becker's Healthcare and Helix for sponsoring today's presentation. To learn more about the content, please check out the resource section on your webinar console, and please take a moment to fill out the post-webinar survey. It really does help us make sure that we're providing great content for you all. Thank you again for joining us today. We hope you all have a wonderful afternoon.